Hello and welcome everyone. We're very excited today to welcome you to our Women in Global Health Australia Unequal Burden for Women in Healthcare webinar. We're really looking forward to discussing systems changes required to better support women in healthcare. My name's Associate Professor Jacqueline Boyle. I am the current chair of the National Committee of Women in Global Health Australia and will be facilitating the overall program today. I would firstly like to start by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. I would like to acknowledge the Wurundjeri and Bunurong people of the Kulin Nation, where I'm coming from today, but also to traditional owners around the country where everyone else is attending from. I would like to pay respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander people who are also attending today. I think one of the really exciting things that came out of the election on the weekend was that we had 8 new Aboriginal and Torres Strait Islander political representatives voted in, and 7 of those were women. So that's actually a really nice way to open things today, I think. So we're going to start today with a talk from Professor Bismarck on the experiences of healthcare workers in the COVID-19 pandemic. Then we will have a panel and then a brief update on Women in Global Health Australia. Please use the chat function, share on social media and use the chat function for any questions. So I will just start by introducing Professor Bismarck. So Professor Marie Bismarck is a medical practitioner, health law academic and company director. She heads the Law and Public Health Unit at the University of Melbourne, where her research explores the intersection between health practitioner wellbeing and patient safety. Her research has been widely published and influenced regulatory policy in Australia and internationally. In addition to her academic role, she also has a clinical role as a psychiatry registrar with Northwestern Mental Health and serves as a board director on the Royal Women's Hospital, HBA Health Insurance and Somerset Retirement Villages. She's held numerous awards and fellowships and has been named as one of the Australian Financial Review's 100 Women of Influence. So we're very excited to have Marie here today. Thank you. So I'll hand over to you, Marie.
Thank you, Jackie. Tēnā koutou, tēnā koutou, tēnā koutou katoa. It's wonderful to be here with you all today. I've been invited to say a few words about gender inequality in the pandemic. I thought I might start just by giving you some personal context about the work that I was doing during the pandemic and then place that into a broader context of what we know about the impact of the pandemic on women in healthcare more broadly. So during the pandemic, I was working as a psychiatry and addiction medicine registrar at the Royal Melbourne Hospital. I was providing mental health services to people on the aged care and COVID wards and in the intensive care unit as well. So very much on the front lines of COVID care. During that time, my husband was caught overseas by the border closures. So I was caring for my children on my own. That included supporting remote learning for my daughter who was in VCE at the time and supporting my son who had lost his job as a result of pandemic-related restrictions. I was trying to balance that clinical work and those carer responsibilities with trying to keep my research and leadership careers going. And then when my own dad fell sick with COVID as the elder daughter, I was the one who provided care to him at home for 2 weeks while he was very sick with COVID. So as I'm sure you can imagine, it was a challenging time. And I think that everyone who's here for this webinar today will have had your own experiences of challenge and difficulty and grief and loss during the pandemic. It certainly felt to me as though my responsibilities as a mother and as a daughter and as a woman trying to make my way in research and leadership careers, that the weight of the pandemic fell more heavily on my shoulders than on my husband's. But I was, really interested to know what the experience of other healthcare workers was. So I was very fortunate with my colleagues Natasha Smallwood and Karen Willis to be involved with the Frontline Healthcare Workers study, which culminated in this book on the experiences of health workers during the COVID-19 pandemic. And I'd like to share some of those findings with you today, I guess, to reflect that my personal experiences of the gender impact of the pandemic were felt by many women across Australia and across the world. So the first area that we heard about was the impact of insecure work on women. So we know that the nature of work remains very gendered, that about 75% of healthcare workers around the world are women, and that particularly in roles such as aged care and in casual nursing roles, that women are heavily overrepresented. Those roles are sometimes precarious in nature, they're often very underpaid. And we heard about the really precarious nature of work for many women. So one ED nurse told us, because I was a casual nurse, it wasn't clear what pay I would receive if I had to isolate. A surgical nurse said, after being casually employed for 7 years, I was suddenly unable to get any work at my hospital. How can a huge public hospital desert us so easily? So we really heard about the impact of insecure and casual work, particularly on women. The second issue that we heard about was safety at work. The chief executive of Vic Health, Sandro Di Maio, says that COVID-19 has not been a pandemic of infection, it's been a pandemic of inequality. And that has really rung true with me, that it's not a pandemic of infection, it's a pandemic of inequality. And we've seen both within Australia and globally the dreadfully unequal distribution of COVID-19 vaccinations. So, for example, within Australia, healthcare workers in major tertiary hospitals were likely to receive their COVID vaccinations ahead of healthcare workers in aged care facilities in many cases. One community nurse said to us that a myriad of socioeconomic inequities have been exposed during this time of global crisis. Many healthcare workers were very concerned about their safety at work, and the provision of personal protective equipment was also gendered. Some of you may know that many of the N95 masks that were made available during the COVID-19 pandemic were designed for European men's faces, and that's reflected in the results of fit testing. So when you do fit testing of masks, 95% of men will pass the initial fit test, only 85% of women will pass the initial fit test, and only 60% of women of Asian descent will pass the initial fit test. So what this means is that female healthcare workers, and particularly women of Asian descent, are much more likely to have been wearing a N95 mask that didn't form a proper seal on their face. One female anaesthetist said to us, this was during the second wave of the pandemic, some hospitals still don't fit test. I know that I have failed fit testing, but I'll still be required to perform aerosol generating procedures. The third area where women were disproportionately affected during the pandemic, and this will come as no surprise to anyone, is through the uneven caregiver burden. So even before the pandemic, the burden of unpaid care already fell disproportionately on women, and that was exacerbated by the pandemic. So around the world, women do about 75% of the unpaid care work, including childcare, cooking and cleaning. We heard from many healthcare workers about how that already challenging role became even more difficult during the pandemic. So one oncologist said to us, I'm a single parent of 3 children. My work is much more stressful and hard because of the visitor restrictions on our cancer ward. Added to this, I'm a single parent of 3 children with the failure of delivery shopping, no cleaner. It's hard. The challenge of remote schooling tended to fall more heavily on women's shoulders than on men's. So we heard that in about 3/4 of families, it was the mother who carried most of the responsibility for supervising remote learning, and only in 1/4 of Australian families did the father take the primary responsibility for supervising remote schooling. So we heard a lot of feelings of guilt from female healthcare workers around this. One emergency nurse said to us, "We've been expected to show up for our jobs with further stress and worry, and then go home and homeschool and care for our children and attend to all home duties as well. We're denied time off work to help at home, and then we're shamed for allowing our children to fall behind at school." Those carer responsibilities didn't just relate to children, they often involved caring for elderly parents, and for some women in the so-called sandwich generation, they had responsibilities both for children and for older parents. So one surgical ward clerk said to us, "It's been hard dealing with my mother's medical appointments, trying to keep her positive while I'm working long hours and keeping up with work demands. It's exhausting, mentally, physically, and emotionally." It wasn't just childcare where those burdens fell disproportionately on women. We also heard about the impact of the pandemic on women's reproductive health. So many of you will have read and seen in the news the delays in IVF and how stressful that was for many women who were trying to conceive. We know that women, particularly women working in surgery, are much more likely to have difficulties with their fertility and difficulty with conception than women in other occupations. And so those closures of IVF clinics often affected women working in medicine. Women spoke about feeling really powerless and helpless and anxious when IVF clinics did close. When women did fall pregnant while working in healthcare, they were often very anxious about the potential impact of the virus on their pregnancy and were affected by visitor restrictions. So one junior doctor told us, "I went through pregnancy and delivery during lockdown. The lack of support was very stressful. My partner was only allowed to visit 2 hours a day. I know many of my other medical trainees are worrying about how they'll safely look after small babies and safely return to work during the COVID outbreak." Some healthcare workers told us that they had abbreviated their maternity leave because of staff shortages at work. One senior doctor working in an emergency department said, "I returned from maternity leave 4 months earlier than I had planned due to staff shortages. I feel that I was robbed of this time with my baby." We also heard from some nurses who were working in full PPE about the impact that had on their ability to keep breastfeeding their babies, that women's breaks at work were often shortened because of the time involved in doffing and donning PPE. So one nurse who was working in full PPE said, "I had to stop breastfeeding my baby as my workplace told me they couldn't afford for me to have a pumping break. I wasn't at all ready for him to be weaned." And finally, one of the real concerns is that the cumulative effect of all of those burdens that I have spoken of relating to reproductive health issues, childcare burdens, caring for elderly parents, worries about unsafe workplaces and insecure work, all have a cumulative impact on women's equality within the workplace. And there was real concern that women were losing opportunities and that their career progression was being set back. And again, we know that this was a problem before the pandemic. One phrase that really resonated with me from our book was that none of the problems in the pandemic are new. What we're seeing is a widening of pre-existing cracks. So we knew that even before the pandemic, women made up about 70% of the global health workforce and about 90% of the aged care roles, but women only hold about 25% of the senior roles in the health sector internationally. The World Health Organization has said, in general, women deliver global health and men lead it. So this was already a problem, but there has been real concern that women's careers and ability to progress has been hindered or even set back by the pandemic. So one female anaesthetist said to us, the impact on my productivity as a female academic clinician has felt much more severe than what I observe among my male peers. Another senior medical specialist said, without better recognition of the impact of COVID on health workers who are mothers and policy and financial steps to change this, this will hurt women's careers in ways they can't recover from. I think what we're really seeing is this cascade of disparities that's disproportionately affecting women in healthcare, and the consequences of this are profound. So the first consequence is delayed progress towards equality. There's a real fear that decades of momentum towards gender equity is at risk of being lost. We've also seen very high levels of psychological distress among female health workers. So our research found that 1 in 10 healthcare workers had thoughts of suicide or self-harm in a 2-week period during the pandemic. One junior doctor said to us, the depression I was diagnosed with before the pandemic has completely spiraled out of control to the point of suicidality. So we're seeing extremely high levels of psychological distress and burnout among women in the healthcare sector. And one of the consequences of this is that we may be losing people from healthcare at a time when we can least afford to lose capable and talented women from the healthcare sector. So international studies have found that around 1/3 of nurses are considering leaving the health workforce. And that was certainly reflected in our survey. So one community nurse said to us, it's the first time in my career that I'm exhausted, lacking motivation and unable to cope with more change. I'm seeking a career change. And several of the women who answered our survey said that they had actually made plans to leave the healthcare sector or had accepted jobs in other less demanding roles. It wasn't just nurses who were speaking about leaving the healthcare sector. One junior doctor who was in physician training said the pandemic has made me want to quit medicine, even after spending most of my life striving towards being a doctor. So we can see that there are some really significant problems that need to be urgently addressed if we're not to see a widening of those gender inequities and the loss of capable and talented women from the health workforce. I'm grateful to Jackie for just giving me the job about speaking about some of the experiences of healthcare workers rather than coming up with all of the solutions. And I'm absolutely delighted that we have such an experienced and thoughtful panel of women to help us think about some of the solutions to the problems that I've spoken about. Thanks, everyone.
Thank you so much, Marie. And I think it's so important that you've managed to capture all of those experiences. It's going to be really important to highlight the systemic changes that are needed going forward, as sad and as they are. I'd now like to introduce Associate Professor Nada Hamid, who will be facilitating the panel discussion. She is a haematologist at St Vincent's Hospital in Sydney, the Director of the Haematology Clinical Trials Unit, the President of the Australian New Zealand Transplant and Cellular Therapies, among many other committees. She's an Associate Professor at the University of New South Wales and University of Notre Dame. And we are very lucky to have her on the National Committee for Women and Gender Health. She's an intersectional feminist with an academic interest in gender equity, diversity and inclusion, and has many other roles apart from the one she plays with us. And delighted to hand over to you.
Thank you so much, Jackie, for the introduction, and thank you, Marie. That was fantastic, and we're very lucky to have you on our panel today. I'm going to introduce the panel members, and then we'll launch into our discussion to discuss perhaps some of those solutions. We have Associate Professor Dr. Faye McMillan, AM. She is a highly accomplished pharmacist, recognized as the first Indigenous Australian to hold a Western degree in pharmacy in this country. Faye is one of 2 Deputy National Rural Health Commissioners and works at UNSW as the Associate Professor in Aboriginal and Torres Strait Island Health in the School of Population Health, with national leadership positions in pharmacy as well. Dr. Magdalena Simonis is a GP, government health advisor, primary care researcher with the University of Melbourne, and a leading women's health expert and advocate. Magdalena's interests are in the community health, chronic disease prevention, and the development of sustainable, equitable healthcare services, and holds multiple board positions with not-for-profit organizations and committee memberships. We have Adjunct Professor Kylie Ward, who's the CEO of the Australian College of Nursing, or the ACN, and is a renowned nursing workforce leader and a passionate CEO who's really shaped the ACN to become a prominent and influential professional organization. And we have Louise O'Neill, who's the inaugural CEO of the Aged Care Workforce Industry Council. Louise has over 18 years of experience in the Australian public service sector, holding positions across health, disability, and communications portfolios. Welcome to all these incredible women who have clearly put a lot of effort and work in advocating for others. I welcome you today, and I'm in awe to be in your presence today, and thank you for joining us. For all our listeners, what we intend to do today is to ask some questions of the panel members, and hopefully we can get some insights into their perspectives of how we can resolve some of these issues. We've just heard from Professor Bismarck, who collected stories from the front line, and really those lived experiences are just incredible to listen to. They resonate so deeply with me, and it's nice to be able to just hear the stories rather than data sets or data points that don't really share the stories of what's been going on. So I asked you today as panel members, can you each provide a quick summary on how your sector is feeling over 2 years into the pandemic, and how could we do things moving forward to support and retain people in our sector? I might start with you, Marie. What do you think we can do in response to those stories?
So I guess, I've had the very privileged position of being able to serve both as a frontline health worker and as a leader within an organisation. So I might put on my leadership hat rather than my junior doctor hat to answer that question. So I serve on the board of Somerset Aged Care, and we recognised very early on how crucial our aged caregivers were to our pandemic response. So one of the things we did is that all of the board members and all of the executive took a 20% pay cut so that we could increase the wages of our frontline caregivers, nurses and housekeeping staff. I think that made a real difference for them, both in terms of direct financial support, but also in feeling valued by the organisation. It's just awful how underpaid and undervalued the aged care sector has been, despite their crucial role throughout the pandemic.
I'd be happy to speak, Nada, to that question as a GP who's been at the forefront from the outset, and also working full-time throughout this period as a clinician and also undertaken some research. I think we're all acutely aware of the role that general practice has played in curtailing the explosion of COVID in the community by addressing issues such as drive-through respiratory clinics, providing care for patients in our car parks, and restructuring our practices so that even without guidance from the government, we were developing our own models of care. We were left out of the conversation at state government and federal government discussions around distribution of both PPE, protection of staff, protection of community. We were also there was a gross failure of communicating through PHNs with general practice groups around the prevalence of COVID within certain sectors so that we could ring belt those areas. And it was through banging on doors and hosting our own independent sessions as groups of GPs, mobilising ourselves to create models of care that then informed. So it was the tail wagging the dog. And I think that as a consequence of that, and it was not as if the first episodes of these frustrations were acknowledged and addressed appropriately, and that we were incorporated in the conversation and brought to the conversation. We found that with every stage of COVID, we had to really argue hard to be listened to. And general practice is really the gatekeeper to the tertiary health system. And we had an absolute lack of PPE and lack of access to proper PPE. And in fact, there was an attitude that only hospital doctors really warranted adequate PPE with shields and NP5 masks, and that we could just deal with the ordinary, blue masks that we still have in our surgeries, and that we purchased our own from Bunnings. So I think I've outlined a heck of a lot here, but what I also want to bring to the attention to everybody is the role that we've played in supporting the mental health of the community. We don't bill according to what we see. And probably 80 to 85% of what we've been doing in every consultation, whether it be over the phone or in person, has had some mental health element to it. And that escapes the Medicare data. So primary care is where mental health is actually managed. And the other thing, and I know that I'm actually stealing the show a bit here with lots of points, but I'm very passionate about our role and the lack of involvement from the outset. And I think that also the other aspect of this is that we have enormous resources within ourselves in our diverse representation to reach community in culled languages, and some of us stepped out and did that too. So I think the other thing is, of course, we were forced to bulk bill from the outset, whereas no other specialty had to bulk bill. So certain practices had to shut down as a consequence of that. So.
Thank you for that, Magdalena. And I think, what I'm hearing is a couple of really clear themes. One is a lack of respect for what certain contributors to the healthcare system bring, or not necessarily just respect, but acknowledgement of what we actually contribute. And the second is, how do we demonstrate that value, whether it's financial or other methods of support? Communication is something that has to be done deliberately. So strategies around ensuring that there's diversity of disciplines and being able to communicate appropriately requires deliberate design, which we found out was not necessarily on the highest sort of priority list, and certainly probably because government bodies were not used to it. So this is probably something we need to take moving forward. And I've got your hand up, Louise, please go ahead.
Sure, thanks, Nada. Look, from the aged care sector perspective, the sector itself's been through not only the COVID pandemic in the last few years, but also a Royal Commission and the outcomes of that Royal Commission that have resulted in significant media coverage and community scrutiny for workers. Particularly, the pressures have been incredible, and the impacts of that, both the pandemic, natural disasters that we've seen, residential services having to be either locked down in amongst fires and trying to provide services with people living in the service, workers living in the service, through to evacuations, and the significant workforce shortages and this ongoing criticism of the workforce. So despite all of that, the sector has remained incredibly resilient, and their commitment to delivering services to older people is very, very strong. And we've been very lucky to partner with an organisation called BPA Analytics, who do pulse surveys in aged care services and in other healthcare facilities and community health. And over COVID times, they've interviewed or surveyed 23,000 employees, and 57% of those employees have indicated that their organisation is still a truly great place to work and that they don't want to leave. And that's incredibly heartening in a sector that has actually been copping quite a lot of pressure. On the other hand, we've also know that HESTA conducted research in 2021 surveying around 1,500 aged care professionals and suggested that despite those significant challenges in the sector, that aged care really returned a much stronger, more positive sentiment towards their employers and the industry during COVID in 2020 compared to in 2019. So in fact, as the pressures ramped up, their positivity actually increased rather than decreased for those that have stayed in the sector. Despite that, we know that there have been a lot of people have actually exited the sector as well. We know the significant workforce challenges across across aged care, like I've spoken about, and both of those pieces of research, highlight that it's a polarised workforce. There's a significant number of unhappy and dissatisfied aged care respondents, as well as a significant number who feel appreciated and want to stay in the sector. But you know, it's a fairly balanced lot, I guess. And you know, if you look at Hester's research, around 1 in 3 aged care respondents didn't feel valued or appreciated by their community or their employer. So a third of people are really feeling that people don't think that they're doing a good job or don't think that they're of value to the community that they serve. And you know, between 32 and 38% of aged care employers are unlikely to recommend their employers or leaders or career in the sector, and that's pretty scathing on a sector that we actually need to be ramping up the number of workers in it exponentially over the coming years. Younger people, professionals under 30, and particularly nurses, were the most likely to intend to leave the aged care sector in the next year or two from that research. So, you know, we've developed some insights from that. We've got a workforce, what's called a workforce narrative on our website that's available to people. It's got 12 insights, and it talks to, you know, it shows the reasons why people are leaving: job security, you know, insufficient regular hours, that they are being underpaid, organisational reputation, many workers approaching providers that they've, you know, heard word of mouth have a good reputation, rather than looking at advertised jobs, but going to those organisations that they see as reputationally strong. Poor management is an issue for people, and lack of work opportunities, and also excessive workloads, and particularly during COVID. So look, the findings correlate across all of the 2 pieces of research, and you know, I think it's incredibly important that whilst wages is not the only answer to improving this in the aged care sector, it's a seriously issue that we see, because aged care is underpaid compared to other like sectors, and you know, the Fair Work Commission is considering that at the moment, so we're waiting to see what happens in that space. Yeah.
So I mean, I will move to Kylie, and I'll come to you, Faye, as well, because I know Kylie needs to leave early. But it sounds to me like some of these themes are actually common to all of the healthcare sector workers. And what might be a potential solution is collaboration in this space to leverage that point, that it's not a divided issue. It's not aged care, it's not just nursing and medical. But Kylie, what are your thoughts from the nursing perspective, which really covers the whole broad range of healthcare services, but also as a predominantly female profession?
Yeah, thanks, Nada. You're right. We're 400,000 registered nurses in Australia, the largest profession, 90% female dominated, and a small percentage of non-binary, and then men. But I would like to come from a different perspective, because I could equally, I completely agree with my colleagues here. The reality is we're talking about unequal burdens for women in healthcare. So if I may have a moment, and I'm going to be frank and fearless and probably say things some of my colleagues won't like, but it's time we have some really constructive discussions. The reality is, in March 2020, we went to war, and we went to war with a virus we couldn't see. And all around the world, the armies, for want of a better word, I know it's all male language, and paternalistic systems that we're used to were female-led. And whether you're nursing or healthcare workers or school teachers or childcare workers or shop assistants, really, I don't think that, as history has recorded other wars, they're going to really embrace what we did and how we stood up. And the nursing profession was very much at the forefront. People were scared. They still went to work. They came home, you know, that somewhat immunosuppressed and couldn't. They carried the guilt, the moral injury of around doing major modifications to their workflow and work practice. We don't have one healthcare system in Australia. We've got multiple healthcare systems with interfaces around money and federal and state. And then we saw a pop-up healthcare system with the vaccine clinics that were needed. And really, the system was already stressed. It's not the first time we've heard ambulance issues in ED and nests and needs and all these artificial targets. And we'd been advocating we needed to move to values-based healthcare rather than the incentive of even activity-based. We're paid for, you know, who we see and occasions rather than outcomes of health population. So we've always been committed to universal healthcare, to primary and preventative health. I think for me, I'm going to talk about this in a way of representing the profession, but also talking about it is almost a quarter of the way through the 21st century. And I'm really disappointed that nurses are still facing things that they faced 50 years ago and 100 years ago and still battling the battles. And I would hope, I've got my professional colleagues here in medicine and in pharmacy, I would hope that we'll either see generational change or gender change. And for me, I've got so many colleagues in GP friends, and we looked after each other at different times through COVID, but it is the younger generation, even some of the male GP doctors, that are less inclined to worry about the billing. But what I ended up seeing was the fight, particularly when it came to vaccines and immunisation. Nursing already is a major contributor to the immunisation rollout. And I think that we could have been in a very different place in the beginning of last year if the lobbying hadn't occurred around the money. But what actually happened in that argument, and I did meet with the Prime Minister with colleagues, but I could see the battle around the dollars. And we've seen there's a phenomenal amount of money that's been made from rats. And what we've seen is a shift of people now diagnose themselves. They'll tell you they've got COVID and haven't even had a test. But for me, it was really disappointing to see it around the payment and around the money. And I understand money matters, but what they forgot about was the nursing profession. So in the facilities, whether it's pharmacies or GP clinics, they were happy to employ a nurse to give at least 4 vaccinations in an hour on the doctor's medical license. And where did that money go? But did they increase the salary of the nurse they pay in the GP clinic to work what they did? And some did. I'm going to be, I was really pleased. And some practice managers have said, well, you can give them another $5 an hour because they're risking everything. But it's interesting. I would hope we could come to a time when there's women in this sector that will actually look after women and female-dominated populations. Because if we leave one behind, so nursing doesn't have access to MBS item numbers or nurse practitioners. And what that then is forced to do is be employed by another professional license to get access to money. And that's where primary care really suffered, really in rural and remote areas, or then the burden shifts to the acute sector to employ people. And that's why we ended up with so many pop-up clinics that the acute state sectors just put massive hubs in, when it really should have been a primary care-led model, even though that would have been, there's only 8,000 GP practices in the country. There's 23,000 GPs. We knew we would have to work together, and then the pharmacists. We could have actually professionally led, but what we did is let government. We played government, and I was really disappointed. And some of these colleges that are I'm the leader of the Australian College of Nursing, but some other colleges have female presidents and female leaders. Why are we not changing for the betterment of women? When you look after women in a society, whether that's professionally or in the consumer base, you lift the social and the economic fabric of all societies. So I am being frank and fearless, but it is a little bit disappointing that we're still arguing over who has access to payment when the system is so burdened and everyone's so exhausted. I have had thousands of nurses contact me over the last few years. There's nights when I've woken up and had 100 messages to wake up to. From all sectors, all services, and some were completely burdened and completely overworked and debriefed to me at 1 o'clock, after a night shift, and others felt completely guilty that they had to step away because they, might have had Crohn's disease or diabetes and couldn't work, and then felt guilty that they left their colleagues. Whilst others, say in Western Australia or Queensland or in places that COVID hadn't hit, would write to me compelling, saying, I feel helpless, I don't know what to do, my colleagues are struggling and I can't help. So even when people weren't caring for COVID and there was the non-COVID to factor in, I think in all of our professions, and I know I'll speak for nursing, because we choose to go into this with such high empathy and compassion, you pick up on the pain body and the experiences of your colleagues. The not being able to sit with teams in tea rooms had a devastating effect, and clinical supervision needs to be implemented for every nurse. And I would even champion every doctor, because I know allied health gets it, mental health gets it, but not having anywhere safe to go and then coming home, or who would they debrief to, and you didn't have it. Well, normally we look after each other in our workplaces. It's not so tribal or territorial. It shouldn't be, doctors, nurses, physio, speech, whatever, really people work really well in integrated teams, but how well are we lifting up our colleagues to have independence and autonomy to be able to meet the needs of community? So I feel like that was an issue that couldn't be helped. But I do see that we did the best we could as a country. We led extraordinarily well. Unfortunately, people did die, but it was nothing like we saw overseas. The aged care sector, for example, has been completely battered, but unless we start to turn our language around, this is the first time in my history of 30 years of nursing that the universities are telling me they're not getting the same number of nurses, of undergraduates applying to do nursing. So we're going to have a pipeline issue in 3 years. The World Health Organization and ICN, before pandemic, we had 6 to 7 million worldwide shortage of nurses predicted. By 2030, that's now increased to 13 to 15 million. So we've got an issue, and if we cannot get our scope of practice and show that nursing is truly appreciated, we don't want to be called heroes, we don't want to be clapped, we don't want tokenistic gestures. Pay is an issue, but so is access to earning a reasonable income. So I think that the reason that I've committed to doing this and to have the kind of colleagues that I've got and strong female leadership is, why don't we all champion for each other? Because the consumer is going to benefit at the end of the day if we all rise to, there's enough work for all of us. There's no area that's, doesn't have high demand. And we just need to think in an abundant way and not territorial or tribal and try and hold one back while the other gains. And that's what I would like to see going forward for real sustainable change for women everywhere.
Thank you so much, Pally. And I think what you're saying there to me highlights that there probably needs to be a little bit more intention to designing teams when we come to, pandemic response. Co-design of solutions is really important. And if people are left out of the room in that conversation, that is very counterproductive. So if GPs are not part of the discussion, that doesn't work. If the nurses aren't part of the conversation, it doesn't work. And I think the prior systems that we've had have lost their capacity to address these issues in the face of a pandemic. This is a new beast, and we need to think about designing our processes and our teams and being deliberate about how we engage with this. And I'm sorry to say that that's really not happened. I think because it was such an urgent situation, things came together very quickly. But what we can learn is that in the future, that needs to be a bit more procedural and with intention. And some countries have done that very well. But I take your point that, if we don't value each other, then there's no line towards success. And really, it's about patience. So gender equity for me is as much about patience as it is about workforce design and development. And I'm coming to you, Faye, to hear about your experiences and what your thoughts are on this question. Thanks, Kylie.
Thanks, Nada. I'm probably going to speak to some of what Kylie just spoke to, though, as a Wiradjuri woman, and I'm sorry, I'm sitting in an Aboriginal medical service coming to you today. As an Aboriginal woman in this country, I think the opportunities to learn from First Nations people who are the oldest surviving culture of this world really has highlighted that we are in moments to be able to do that. And I think, as we're moving into Reconciliation Week in this country around the opportunities to actually take some of those lessons, the position and the intentionality of the matriarch and what women bring to First Nations cultures, and those opportunities are part of our learning more broadly across society, and obviously how we start to position ourselves. But talking to that this is a new environment as we move out of a pandemic, but what we knew from rural and remote workforces were that prior to the pandemic, we already had an under-resourced, and we were already experiencing challenges in attracting and retaining a workforce. And then the pandemic created opportunities, particularly for women who were in multiple workplaces and multiple work positions, that the pandemic meant that particularly in border communities where there were border closures, that they couldn't then participate in the workforce in some of those where they were working across multiple health sites, that it forced them to be in a one employee type of model, which then limited their capacity and that, you know, the restrictions were then also done through communities that were relying on locum workers to fill what we already knew as. So what we had was a huge community response from those within the community that either, you know, came back out with skills. And in the allied health workforce space, what we actually saw was the skills of the allied health workforce being recognised as more than what was seen as, you know, the podiatrist only looks at your foot, as opposed to the other skills that they learnt through their education and training that could be then utilised to support a multidisciplinary team that is really part of what we need in rural and remote Australia, is this recognition of the multidisciplinary team and how we do that together. And I think that's the strength of rural and remote communities, is that people are more interested about each other and how we get the job done. And so when you look at the responses that came about, and yes, you know, women were impacted because of all of the issues that have already been spoken to, that it showed the depth of the resilience and the capacity of community to come together. But, you know, it's about how we provide care within our communities, how we create that continuity of care that allows community to stay where they are. But the other part for many rural and remote communities too, that prior to the pandemic, we were already in recovery from natural disasters. And so this was just an ongoing, and as you spoke about, it's demonstrated the depth of the resilience and the capacity of communities to come together, led predominantly by women in the health workforce space, getting on and doing the job. Yes, you know, and in the background of all of those things that were happening, there was the politics, there were, you know, boardroom decisions, but you were still seeing people that were working in communities getting on and doing it. And as a community pharmacist, the other part to that, and, you know, this is not business aside, that, you know, when we were locking acute facilities down for those that desperately needed it, what we also saw was other workforces that were stepping up and putting themselves, as we said, you know, going to work every day because they were essential workers, and then going home to our families and our communities in the fear that we are potentially, you know, bringing back to our communities the very thing that we are fearing. And the other part too, that was the judgment calls on communities that don't look the same as many other communities. And so for many First Nations communities where, you know, the Aboriginal community controlled sector did such a great job at the start of the pandemic, and then when it did start to move into our First Nations communities, the judgment by people of overcrowding, of cultural practices that were then needing to be separated because of the pandemic response that was required. And the majority of that fell to the matriarchs of our community to navigate and try and position the health responses that were required for the communities to make sense of it for cross generations. And that's, you know, these moments of learning that, as I said, as we move into Reconciliation Week, give us such a wonderful opportunity to truly be in relationships with our First Nations communities that are offering, you know, this extensive knowledge of being the oldest surviving culture in the world.
Thank you so much, Faye. And I think it's really important to recognize that culture gives us the opportunity to learn about how to do this. And this is a moment in history where we can lean on how people do different things, because the current infrastructure, which is predominantly a patriarchal, you know, post-colonial structure, has not worked for this particular purpose. And there is much to learn in how do we adapt and learn from each other as communities and cultures. One of the things that I love about what you just said, Faye, is that, you know, women are, for whatever reason, whether it's the way we're conditioned or the way that we're trained or the way we're built, really lend themselves well to this kind of work. We're the first to get to a scene, roll your sleeves up, let's get this thing done. Who else needs what? You know, prioritizing other people's needs is what we've been doing for generations and for eons. And so, you know, the concept that we are not front and center in this in history really bothers me. I think it needs to be written down somewhere. We need to acknowledge it, write it down, immortalize it in history. Well and truly the kind of things that have happened in every profession, and you mentioned this as well, Magdalena, that we design models of care to suit our needs because the overarching response did not go deep enough, was not specific enough, and was not tailored enough to our individual communities. So there were many people, predominantly women, designing and developing care models everywhere across the country. And that has not been acknowledged. It's been left to, the merit has been put down to state governments and federal governments. But in reality, in every single community, there were some really nuanced and specific needs, particularly in rural regional Australia, that were only addressed by the people on the ground. And that speaks to community, to the commitment of the service of others that happened on the ground. And so I'd really love one day to have this group write something about this and really immortalize it, because I see what you've done here. Magdalena, you've got your hand up.
Yeah, I agree entirely with you, Nada, and I think that it requires all of us together in a room to have these conversations and to design a better way forward, because we've learned a heck of a lot through this and through our various disciplines. But very few times did we all have the opportunity to talk about what we were doing and what our issues and pain points were. During this time, I did actually take the opportunity. It was an opportunistic thing I did, which was to conduct a survey, an international survey on women doctors during COVID, during, what was pretty much the tail end of our first wave. And I had a look at, had responses from around 42 different nations of women doctors, ranging from predominantly really 35 and over responded. There are, around 1,500 responses, 75% full response rate. But what their issues were, and the distribution of GPs, the largest number were from Sweden, Italy and Australia who responded, and the other countries were sort of in smaller proportions, but and so some of them are clumped together, and I'm currently writing it up. But the issues that were raised internationally were very, very similar. Although if you worked in general practice and in primary care, some of the issues were very different to those if you were working in accident and emergency in the hospital system, or if you were a surgeon. However, across the board, the leadership, as you said, of women during this period was really significant. A good 30 to 40% were in some way involved in educating and improving health literacy within their communities. And many stepped up and took on government roles and advised government. So this was probably something, as you describe, really undiscussed and uncovered. And also, I think it points to an appetite for this that we all have, a readiness for this that is as yet untapped. And it really is very exciting to think what could happen if logically that were tapped into and we were invited.
So that power of women harnessed to leverage what we actually offer and change the language of what merit and what is required for the job. Because if what is required is what women bring, then everybody wins. I'm going to move slightly into solution mode, because there's the next couple of questions that I intended were around flexible work and parental leave. And I think this probably applies to everyone. Flexible work arrangements, particularly the option to work from home, has probably been a positive outcome for many people in this pandemic. It hasn't been a luxury available to frontline health workers in the past, and it may not lend itself to nursing, but certainly for medical professionals or people who don't actually have to be on site, this has been a bonus. We don't really know what flexible work looks like in healthcare, and I'd be keen to hear positive examples. But one of the other things that comes to mind is that, with working from home for women comes the issue of caring for others at home at the same time that has been highlighted by this pandemic. And in 2021, Australia ranked 70th in the Global Gender Gap Index for women's workforce participation, a fall from 12th place in 2006. And a primary reason for this was that our parenting policies make it more difficult for Australian women to continue work after having a child. Healthcare is a female-dominated industry. And what impacts does parental leave have on our respective workforce is a question that remains to be answered. So I'm going to combine these two concepts for you to answer because we really have to address the elephant in the room. We could work from home, but at the same time, you know, our duties at home and our parental leave policies don't make it feasible for us to do both equitably with our male counterparts. I've got Faye, have you got your hand that's new, or is it a legacy? If it's new, go for it.
I think one of the challenges is changing the way we look at, you know, caring leave responsibilities rather than just parental leave responsibility, in the recognition that a lot of cultures and, you know, a lot of intergenerational living actually requires care for multiple different generations. And that, you know, the notion that we only have parental leave, and, you know, there are some smaller provisions for carers leave, particularly after your children have grown and all of a sudden stop being, you know, needy. And it's like, you know, I'm a single mother of 2 teenage boys. I'm sorry, they're more needy now than they were, you know, when they were little. We've got to change the language in the sense of, and recognise and value the points of care where people may be required to take, and how we manage that so people don't feel that they're losing positional or professional knowledge, so that when circumstances change, and if they can and they want to, that there are opportunities to come back in very different ways. Because, you know, we still feel pressured when we do the return to work to swing back into the full-time work really quickly, because it almost demands it of us if we want to stay in the game and at pace with other colleagues that may not have had the same personal experiences or, you know, circumstances that require that. And, you know, and then there's people who have choice that don't necessarily have children but do have other caring roles that you need to consider as the holistic view of how do we sustain a person to stay in the professions in a healthy, particularly a mental health way. Going to the other part around, though, the flexible work environments, I think, you know, as you say, there are some professions that it's not going to ever be possible. You know, there is that reality to it, although innovation is looking at, you know, different ways of how we can get shopping without actually, you know, doing online, without people needing to necessarily be there, but that's a different thing. Within the allied health, I think what there was is the recognition that the experiences of telehealth, not as a replacement for the physical opportunities to engage with your health professionals, but as an opportunity to ensure that that continuity of care could be done both by the practitioner and by the individuals themselves, meant that, you know, it's now an ongoing option from the government, that people do have choice. And particularly for rural and remote communities, that sometimes getting in to see their health practitioner might mean several hours day round trip, that opportunity to say, I feel quite well in this moment, so I could participate in a telehealth or a telehealth option, as opposed to that impulse that not only then has physical, financial, but increases risks for rural and remote communities to participate fully in their own health. So there has been some positives that have come out of these experiences for those professions where it can be. It's meant that we've learnt how to do things differently, how we can provide professional development education so that the isolation for the people in professions. So it's a whole of suite opportunity to look at how we can do things that allow flexibility, not just in the workplace, but in professional development, in education, but in how do we support each other if we're not physically able to get together, and we've learned how to do that so much more effectively. Still not perfect, doesn't replace, but it certainly means that it's an option and that people have choice.
Thank you for that, Faye. And what I'm hearing is that we need to be able to integrate some of the positive things that have come out of COVID. I have to acknowledge, we have had to be much more flexible than we ever could have been before. There was once upon a time that a telehealth meeting would have been virtually impossible to convince people to do. And now this is something we've done. So we've had to learn to adapt quickly. And so, leveraging that is really important so that we can keep those things. And you're right, I think language definitely needs to change. We were still not there yet with the appropriate language, and the need to really look at a family unit as a village rather than individual dual parents, because I don't know how that works. It certainly doesn't work for me. I've got 3 young kids, and you can't do it by yourself. So I totally agree with that. Louise, you've got your hand up.
Yeah, just to add on to Faye's, and look, I before my role in government and in this role now that I'm in, I was a registered nurse for 22 years in a mostly emergency ICU. And I found myself in a situation where I was the single parent of my beautiful 3 Mununjali Aboriginal girls who I brought up, largely on my own, but I couldn't sustain working shift work, and the wages at that stage for RNs was not enough when I was living in Canberra to survive. So I went into work in government. That's how I ended up in government. It was a move to necessity, really. And my story is that the reason I'm telling you this is that we've continued to lose people from all health sectors and all care sectors because of the most vulnerable people in our society, which is women bringing up young children, are trying to actually deliver this work, whether it's everything from doctors through to your personal care workforce, and unable to be supported to deliver those roles while bringing up children and raising families in really vulnerable circumstances. And so we lose people more often than not because they want to leave, but because they have to leave to survive. And it continues to happen. The other things that can, and so there are ways that I think we can support people to stay in, and we see people, there's organisations like Group Homes Australia as an example, who are working in aged care and disability, who have set up self-rostering, and that the same people work in the same homes and they look after each other as staff as much as like a family as they do for the people that they're working with, supporting in those homes. So they support themselves to actually be able to roster in and work the hours that they can do rather than what they're told to do. And having much more of that sort of, and I think Faye was talking to some of that as well, but those sort of supportive ways of working are incredibly important going forward if we want to retain people in health and care. And also, aside from technologies, how do we actually ensure that people are in a safe employment situation? And I think casualisation has become such a big thing for care sectors across the board, and it is not always safe. It's not always supporting the workforce in an insurance perspective, or that people don't know what their rights are in those sort of casualised arrangements, and they don't have the time or the capacity to often find out whether they are insured correctly or supported to do the work that they are on. That sort of platform work that's arising in care sectors more and more often. And I found myself working in those sort of casualised arrangements many years ago, and often it was men that were employing me through a casualised arrangement, and I didn't realise what I never thought to ask how was I insured at the time, or I just did the job. I needed the money, I did the work. And I think that's where we need to really support our care and health workers going forward.
You bring a very good point, Louise, that there's a certain element of vulnerability in the workforce. That means that, the predominant group tends to be the group who are women, because we're a majority female workforce, so we're likely to shoulder that burden more than most. And that vulnerability extends in multiple professions, between nursing and in medicine, where there's short-term contracts that are very common within training schemes, that mean that people really will do a lot of harm to their own families and will take away from their personal lives to ensure that they remain in the workforce. I think that is something that's under-recognized, and perhaps an unintentional a consequence of the patriarchal system that the specialties or the professions evolved in, and probably needs to change. One of the things that I experienced working in Canada was the completely unusual situation where if you were going to go on maternity leave, they would have two people for 6 months overlap, so that the person who's covering you could take over your position comfortably. And it was an incentive. So women who went on maternity leave meant the department, for example, had two people for 6 months, which was really quite positive. So no one really felt terrible about women going on maternity leave, unlike the really negative sentiment when you're losing someone. It's a moral hazard to hire a woman rather than an advantage. So that experience really showed me that, you know, with simple policy change, you can actually make it a positive thing to hire women, which is why they like doing that. And the second thing, the unusual circumstance where they say, if you need childcare, it comes with your job. So, you know, in the same building, you know, you're medical, you drop your kid off, you go upstairs. If something's wrong, you come downstairs. It's simple as that. That is a privilege that is exceptional, but it actually means that the dramas that come with being a woman in the profession are really minimized to an extent that you're happy to be there and you're happy to give. So we really haven't addressed the issue of childcare, but I think it's a failing of the system that it's not even acknowledged and as an issue that needs to be supported. I'm conscious of the time, and unfortunately we could be talking about this forever, because I love having you all hear all the perspectives and insights, and particularly the research you've all done and discussed today. Just highlights that we are coming to this with data. We're not coming to this simply with our own personal experiences and our own lenses, but really bringing in information that could support policy change. And one of the things we wanted to talk about today was policy change. And in Victoria, you know, the Workplace Gender Equity Act was recently passed in 2012, although that's not so recent. It's recent enough that the change we're seeing is taking its time to get here. And this required private sector employees with 100 or more employees to report against 6 gender equity indicators. It was passed in 2020, and it has potentially had an impact. I think it's probably still too soon to see what that impact is, but we don't have that in other states in Australia, and potentially this may be a beacon for change, so that we're looking forward to seeing some of these changes in our health professions. And perhaps that could be something that improves the outcomes that we can learn from the COVID pandemic and bring that into the conversation as well. Any last comments from the panel? Because it has been an absolute pleasure to listen to you all, and I'm aware that a couple of us have had to leave. Go ahead, Marie. And then
just one very quick last sentence that a few panelists have said that I wanted to pick up on, about the way that we care for ourselves and learning from matriarchs and women's ways of doing things. And I think one of the main things I learned from my research is that we really overvalue self-care and we undervalue collective care. Mm-hmm. And I think there's a lot to learn about women's ways of doing things, and that recognition that our own personal well-being is so interconnected with the well-being of our friends and our families and our colleagues. And I wish we would be able to shift the conversation a little bit from self-care during the pandemic to collective care.
I love that, Marie. We're always talking about self-care. I'm like, I'm sorry, my self-care is inextricably linked to my children's health-care and well-being. Go ahead, Magdalena.
In addition to that, I agree that it's community care, and we're all part of a community in our village. As you were saying, Louise, we can't raise children on your own. You need a group, and you too, Nada, said the same. We've all experienced it. I think this is one of the first times I've actually seen so many male colleagues talk about the issues that we were talking about also. I found that the conversations that were being had, that there were more opportunities for us to talk at a level playing field regarding the stress of working during COVID and the challenges we face dealing with the overburden of work, the overburden of responsibility, the fear of contracting the disease and spreading it to our loved ones, social isolation, the mounting housework and concern around their children's well-being. So as a GP, I also had numerous telehealth consultations with men who were suffering and very intensely during this period, and I was having very similar conversations, and they understood more and more. I was hearing, I don't know how you women do this. I just don't know how you do this. And I found that the first time I was having many of these conversations, and I think there's also when you referred to the positives of this, and I think that this is probably something also that we can highlight, that given that there's also a readiness perhaps in the general atmosphere to have this conversation around we're in this together, and this has uncovered the systemic issues, the systemic inequalities, how nonsensical it is because everybody suffers in the end. So let's just bridge that gap.
Yeah, 100%. I think the positive note always wins, I think, and there's so much that we can take away from this. And I personally have taken a lot of points that I'd like to bring up at my next time I talk at some of these sessions. Thank you all so much for being such extraordinary human beings and carers for your communities and the people that you lead. And I'm going to send it back to Jackie, who's going to take over from here. But thank you so much for this extraordinary conversation.
Thank you.
Yes, I would just like to echo that. Thank you so much, everyone. It was really a great discussion, and this has been recorded and will be available on our website. I was just going to finish up with a brief overview of Women in Global Health and encourage people who have attended today to join up and to and to share with your colleagues about Women in Global Health. So I think certainly what everyone has been talking about, and that sort of cross-sectoral and really collaborative approach to improving policy, is what Women in Global Health is about. And they are doing they've had a lot of work and a lot of initiatives, such as trying to advocate for pay, so to get rid of unpaid healthcare, particularly in the Global South, improving pay. They really did it, have been working to address that PPE issue that was raised earlier in this conversation, advocating for universal healthcare, and also around stopping abuse and harassment of women. They are now recognised, have official status with the WHO this year, and actually today and tomorrow they are at the World Health Assembly, and there's a couple of sort of side events that they're organising that you can join if you go onto their website. So I think there are some real opportunities there. In terms of what the Australian group has been doing, so we have really been setting up ourselves and looking into our governance, and we have 3 groups. So this event has been brought to you by the National Gender Equality and Health Leadership Committee, and there'll be other events from the other committees going forward. In terms of the National Committee, this is our group at the moment, and we are looking at, we've just been trying to work out what we can do as a group. And one of the things that we've been doing is looking at the reports that are delivered by women, led by men, and how we can maybe look at this in a bit more detail and how that works in the Australian healthcare context, and how we can drive change there. So some of the proposed actions that we've been doing is looking at policies, working with the Advancing Women in Healthcare Leadership Partnership, and looking at policies related to flexible training and parental or carer leave, which was very rightly highlighted, I think, by Faye. We're starting with specialist medical training and professional medical colleges, just because it's obviously a very broad area, and to look at the impact of these policies, and then expand more broadly after that. Also looking at occupational segregation, and one of the things that we have noted is it's relatively easy in some ways to find out the breakdown identify male and female in terms of occupation, but not anything more diverse in gender. And also if we look at it by any other intersectional lenses. So that also is a bit of a gap that we're looking at. How can we approach that and how can we have that displayed and transparent? Because it's not just about advancing, one group in healthcare. So that's it. We would again encourage you to share this presentation that was so fantastic. Thanks again to everyone, and please join Women in Global Health and look out for our next webinar. Thank you.